because a topic which has always baffled me is stroke. And to talk about stroke, we have none other than the great Dr. Shakir Hussain, sir. A great welcome to you. And on behalf of the Believers Medical College, I want to thank our neurology team who put forward this effort. Anil sir, Jobin sir, very close to me, very humble, excellent human beings, excellent neurologists. So I hand over this stage to you, sir, to invite Shakir sir to our platform, and I think it's a great blessing. So welcome to you, sir. Welcome.
Thank you, Vivek. Good evening, sir. It's really an honor to invite you to Tiruvalla to our Believers Medical College webinar. And I think in 2012, July or September, I met you nearly 10 years back. Hope you remember that.
Yes, of course, I remember.
Sir, to the participants, sir is the former professor and deputy head of intervention neuroradiology in University. And sir is a member at large executive committee World Federation of Therapeutic and Intervention Neuroradiology, WFITA. He's also the director of SNIM, Neurointervention and Stroke Fellowship Program in Baby Born.
Anil sir.
Without wasting time, let me request to start the presentation. Thank you, sir.
Well, thank you, Dr. Anil, Dr. Vivek, and eminent faculty of Believers Hospital. It's a pleasure for me to address this August gathering. The topic for today we are going to discuss is what is new in acute stroke management. So I have reformatted the movement, the moving from ages, moving with the ages, the recanalization in acute stroke treatment. And why we call about a recanalization in acute stroke treatment is that this is the most physiological or natural way of dealing with the problem of the patient with a stroke. So stroke revascularization remains as a front line or the most effective way of treating the stroke. And in the recent past, in last almost more than 2 decades, we have seen that IV thrombolysis, which has been established as a standard of treatment in acute stroke management, has given quite a significant benefit to many of our stroke patients. However, with the IV thrombolysis application globally, which has gone into millions of cases, we have learned one thing from it, that the recanalization rate of IV thrombolysis is not 100%. In the best of the circumstances, it is achieved in about 30 to 40% of the cases. So there has been a lot of advancement or a lot of learning of knowledge base that we had. So which are those cases which do not recanalize in spite of IV thrombolysis given within the time period of window period, or sometimes as early as possible within 30 minutes of the onset of the stroke, but it does not cause recanalization. So the advancement of understanding that we had with particularly with the advent of neurointervention, which started with the hemorrhagic strokes more commonly in the last 2.5 decades. And now we are embarking this interventional technique to acute stroke management also. So what we learned with the microangiographic assessment and angiographic assessment of these cases, that the large vessel occlusion, which is of a different etiological nature or with a large clot burden, does not respond to IV thrombolysis. And these were the cases which were targeted for mechanical thrombectomy in the past. So several trials were undergone, like bridging trials and many other trials in the past. Before, I would say 2009 or 2008, we had until 2010 we had many trials undergoing, but they were all negative trials. They were not proving efficacy or safety of the interventional treatment of stroke. The turning point came with the publication of a MR clean trial. MR clean trial or Mr. Clean trial, which was published from the Netherlands, that mechanical thrombectomy is a new frontier for benefiting the patient by recanalization. So IV thrombolysis even today remains as a front line of the treatment, and we call it as a bridging. So after giving the frontline treatment of IV lysis, we bridge these patients to the angiographic workup to find out if the mechanical thrombectomy can be performed. And when we talk about the mechanical thrombectomy in acute stroke management, we meant for internal carotid artery occlusion, middle cerebral artery, what we call the M1 occlusion, or the basilar occlusion. So these are the target areas or target vessel which are generally considered for mechanical intervention. Now there are several factors which determines the indication for direct thrombectomy or for the bridging thrombectomy, which includes age, window period of the onset of the symptoms, etiology of the occlusion, nature of the clot. Because let's say, for example, in a paraneoplastic syndrome or a patient with cancer, the clot nature is completely different than the clot which is originating from the cardiac source of embolization, for example, from atrial fibrillation, which is the red clot, which is highly vulnerable for IV thrombolysis as well as for mechanical thrombectomy. However, the clot coming in a patient from paraneoplastic syndrome is a white clot. It's a platelet-rich clot. It's very refractory to IV thrombolysis and also refractory to the mechanical thrombectomy because it's a relatively rigid clot, sticky clot, which does not come out en masse in one go. Another important factor is the clot burden. So what is the volume of the clot is another important determining factor. So larger is the clot burden, less effective is going to be the IV lysis. And same is true for thrombectomy. But thrombectomy is very, very effective in a large clot burden, a clot burden of 3 centimeter or 5 centimeter in nature, or sometimes we have taken out even 10 centimeter long clots. You completely recanalize those vessels after removal of those clots. So large clot burden is a very good indication for direct thrombectomy or bridging thrombectomy. Then one has to consider the technical challenges which are directly attributable to the learning curve of the operator. So this is an important parameter, again, things to be considered because indication, let's say, for example, with me would be relatively less, and a center which has a much higher level of learning curve as compared to me will probably have a better results, and vice versa. Last but not the least, in our environment, in Indian subcontinent particularly, the economics is a very important driving factor for the treatment of the patient. This is in a way, as a professional, I would call it as an unfortunate part for me, because I do know that in a situation of where I'm helpful to recanalize this artery, I cannot do it because the patient does not have the money in the pocket, because the devices are quite expensive and the procedures that overall costs are quite expensive in this sense. And that's a frontier we are working on to minimize as best as possible in our own ambit. And working at a Taluka hospital in Perintalmanna over last, I would say, more than 1.5 decades that I'm coming on to. It's a great learning that I had, that how to organize in a cooperative setup, low-cost treatment possible to the rural population of the country. This is one of our mission approach also through our foundation, which is the Stroke and Neurointervention Foundation. And it gives us a extraordinary learning in terms of creating the same result, but with defining or modifying your technique or tools that you use in recanalizing. Vis-a-vis, when I do the same procedure in Zurich, for example, where there is a plenty of materials and no cost implications are onto my mind, I can do completely different work over there without any thoughts. However, when we determine the technique of the mechanical thrombectomy, again, there are different techniques which are there, varying from retrieval technique to suction thrombectomy to combined technique to primary stenting and so on and so forth. Again, which technique will we be using, which will not be using essentially the same, what you call continuous way, in an autistic way, the same technique of just retrieving the clot without understanding the etiology, for example, of the problem. Because etiologically, if you have an intracranial atherosclerotic disease and occlusion of a by the thrombus, the technique will and the success will be completely different than a clot which is coming to a normal artery from a, let's say, cardiac source or an artery to artery embolization, where the vessel, intracranial vessel, is normal, against the intracranial atherosclerotic disease where there is a plaque in the middle cerebral artery. So the technique has to be modified and has to be thought of and implemented. Otherwise, not only that you will not create a positive result, but actually create a repetitive attempt more autistically and will cause harm to the patient rather than the benefiting the patient. So the approach, what we follow is the primum non nocere should prevail in your mind at every step of the decision making and your action that you perform in this way. So there's something. Again, as I said, economics also define the technique. So it's a dynamic decision making. It's not that we start with a decision and it remains constant. It is a dynamic at every step of intervention that you perform. And this is of paramount importance for us because a stroke is a dynamic disease. Even though you are in a procedure which is taking, let's say, for example, 15 minutes of time to recanalize versus 2 hours to recanalize the artery, you are going to expand the what you call the core of the ischemia. So sometimes you take long time and you make a futile exercise, angiographically very attractive results, but clinically not transforming into the clinical recovery. So that doesn't give me a very satisfactory what you call pleasure of the professional intervention. So the stroke revascularization is a concept which is to be learned and understood by the people who are performing these procedures or which were involved in the management of these cases. And one of the important concepts that we talk about is the cerebral blood flow, understanding of the cerebral blood flow, the concept of penumbra that we have understood through our advanced imaging, the understanding of the collateral circulation and the clot burden, how to determine. They all have a direct implication in selection of cases for IV versus mechanical thrombectomy or combined, and the selection of technique, or sometimes keeping our hands away from that patient for a conservative management. Because sometimes we can predict that our intervention will cause more harm and more secondary strokes than a benefit to the patient. So let us look at the cerebral blood flow. So the normal brain receives a blood supply of about 50 to 55 milliliter of per minute to per 100 gram of the volume of the brain. When the blood supply goes to the half, 50%, it is around 30 to 25 milliliter, the ischemia starts setting in. And the penumbra starts at around 20 to 10. It remains as a penumbra. If it is not addressed in time, there is a constant irreversibility which happens the moment it goes below 10 milliliter per 100 gram per minute. There may be a perfusion, but it is very slow and very low pressure. Then the oligemia is setting into the core and the tissue gets into the necrosis. And the necrosed tissue does not give rise to any what you call recovery, because there is a complete failure of the sodium potassium pump and there is a cell death already sets in. So if you recanalize after the cell death has set in, it's a futile exercise of recanalizing. So there is a cascade of phenomena at the molecular level that sets in. The moment there is an interruption of the blood supply to the brain, there is ischemia, there is a decreased energy production, release in excitotoxins, and the activation of leukocytes. All three mechanisms, they progress in a cascading manner to give rise to formation of the cell, breakdown of the cell membrane, and it is the cell death then eventually. So the penumbra concept that we know from the CT perfusion study and CT what you call angiographic study, if you particularly examine the source images of the CT angiogram, you can have a very good understanding of the normal perfusion versus oligemia and penumbra and the dead zone. So it is a time-dependent mechanism. It's in this cartoon. What I'm trying to show you is that the center part is the core, which is in the black. The red part is the penumbra, which is a possible if you reperfuse this area in time, it is revived. It can be revived. And the oligemia is again the zone which is constantly going into the penumbra and into the core over time. So this is, say, for example, at 2 hours, this is a CT finding. If it goes to the 4 hour, you see the core starts expanding and the penumbra becomes smaller. And at 6 hours, there is no penumbra, but just the core there, and the oligemia, which actually is not a complete cell death, which survives eventually over a period of time. So the core becomes the full penumbra, the whole penumbra becomes the core. At this point of time, there is no point in recanalization by any means. And that's where we learned that IV thrombolysis beyond 6 hours of the window period in a conventionally, in an average cases or in conventional sense, is ineffective because the core sets in at that point of time. But there are many exceptions to this phenomenon of the core, which we understood later on with the collateral circulation. So in the beginning, we used to call it time is the brain. This concept was sold over last 2 decades very heavily. And we rushed to the patient, time is brain, which actually comes from the Frankenstein's statement that time is money. So they transformed into time is brain and brain is money. So I don't think it is the biology the nature has created is so mathematical. So there comes a point that, of course, time is important. Time is a very important dimension in our life, but it is not exclusive in biology. It may be good in social system, but not in biology. Biology has its own another dimension, which is unknown to us, which we try to explain through either by means of God or by boson particle or any other phenomena of the cosmic nature or metaphysical nature. So that dimension is definitely there, definitely existent. But what we learned from IV thrombolysis protocol, that time is an important contribution to our action. So if you intervene within 180 minutes of the onset by any means, of course, we have to rush the whole thing into a very high speed, chasing the time. Then you have a good transformation of the oligemia and penumbra into recanalization, which makes it the survival of the neurons. And the survival of neurons, they quickly returns the function. Sometimes as quickly as within 30 minutes of recanalization. Patient improves completely from aphasia, hemiplegia, for example, of the left side of the brain. Now, what we found is that IV-TPA recanalization rates are achieved best in the form of about 30%. And there came in the middle time, in late 90s or the mid 90s, we started using intra-arterial RTPA, which gave rise to a higher rate of recanalization because here you instill the low concentration or low volume or low dose of thrombolytic agent directly into the clot. And high concentration over there causes clot busting phenomenon. So do you have a higher almost to the double tune, 60% recanalization. And mechanical thrombectomy causes as high as 80 to 90% recanalization rate because it is angiographically demonstrable or angiographically controlled modality to intervene. And what made the difference is this small device. This is called a stent retriever, which was actually not developed for the purpose. It was developed for the stent-assisted coiling in the wide neck aneurysm cases that we were using, but its use was done accidentally in one of the situation, and following which it became into the popularity and it became established as a main device today for retrieval purposes of the clot. However, you know, the phenomena of stroke is not different than the myocardial infarction or the limb stroke, what we call. If the artery of the leg is occluded, the common iliac or the internal iliac is occluded, it gives rise to a severe ischemia of the leg. Same way that if the coronary is occluded, it gives rise to myocardial ischemia. If the M1 is occluded, it gives rise to a brain stroke. But you see how the tissue perfusion or how the tissue gives a different strength to the tolerance. And that is all because of the organ which is so delicate and so precious. A very special organ this is, because this is the most, I would say, evolved organ of the human body, which is least understood by us even today. Because what we know about dimension of the brain is only in the form of few functions, the motoric, speech, and all these somatic functions of the brain. We do not know deeply the emotional functions and the metaphysical function of the brain, what connects to the mind. So even to the somatic functions, which we know, which we examine in a neurological examination, which takes about 1 hour at least today, even today. We understand that the different part of the brain has its own complexity and beauty of vascularization, what we call the angioarchitecture of the normal brain, which is quite different from any other tissue that we have. And these vessels are very specific in the sense that they are actually hanging into a system called subarachnoid system, which is bathing with the cerebrospinal fluid. They are not actually attached to any tissue. Their morphology is also different histologically. So they are very special organ as a suspended in a special organ, which is called subarachnoid system. And the whole understanding of this macro level understanding and micro level understanding is very important in our work, because the problem comes from the microcirculation. Let's say perforated injury, a tiny clot goes during this procedure. You remove the large clot, but a small tiny clot goes to the choroidal artery. It gives you a more devastating stroke than the large artery occlusion gives you. So that is why the reward and the punishment of the interventions are very, very glaring and very, very obvious in terms of loss of function of the brain. And that's why it becomes very, very special for us to make it successful or attractive for the large masses for acceptance into the treatment protocol. I'll briefly dwell upon the collateral circulation, which is a very, very important aspect actually, and which we take into account into deciding the indication of the. So when the vessel gets occluded, the nature provides many sources of alternative collateral circulation, which is very apparent for us to understand, because it's such a precious organ that he has created. So he will not create an organ, the circulation to an organ which is so precious, without creating an alternative pathways or alternative support system if there are some failure to the conventional pathways. And that's what I would say we discovered through collateral circulation, which are two types: extracranial to the intracranial circulation and intracranial collateral circulation, which essentially comes through the means of what you call different circulation. So extracranial circulation comes to the pathway of external carotid to the ophthalmic to the intracranial vessels. Intracranially, you do see from circle of Willis and from the leptomeningeal circulation. And based on this, today we define the triaging of the patient. So how we do the triaging of the patient? Patient of the stroke which comes to us, they classify into 3 modalities of treatment. It could be the medical management. That means if we decide that patient is out of the window period, collateral circulation is inadequate, core is established, revascularization is not going to work in this patient, these are the cases which will directly go to the medical management. But there are a group of patients which are large number, which are majority, I would say more than 50%, 70% cases, they go to the IVTPA wing quickly. But at the same time, they have to be bridged to the endovascular modality. So how do we evaluate? And I will show you briefly the protocol that we follow. This is, I have modified from our Zurich protocol. This is what do we see that patient when they come to the emergency. We call it a Notfall, but it's emergency. So neurological examination is performed, laboratory investigation, NMSS is done, and ECG and ultrasound examination is performed over here. And patient is after this quickly, it is seen by the emergency medicine people. And we have an emergency stroke team which gets a code, and they immediately, before actually the patient comes to the emergency, they reach there. Because we have a code system which we get stimulated the moment the patient is alarmed by the peripheral center. So the whole team gets activated, then they're ready to welcome the patient in the emergency room. And they will, after the initial examination and laboratory blood testing, which takes time less than 5 to 7 minutes, and quickly transport the patient to the imaging center, which is very nearby. And we follow either the CT, commonly we follow the CT protocol. I'll talk about the CT protocol versus MR protocol. And after this, if this is a candidate for IV thrombolysis or not, based on the CT, they will start IV thrombolysis if it is inclusive criteria without asking the neurointerventional team. But if there is a large vessel occlusion seen on CT angiogram, then the neurointervention team is immediately informed. And we as the neurointervention team always remain at home. We can access to these imaging at home also. And if it is to be indicated for mechanical thrombectomy, we give a green signal. And then comes another important, which is the anesthesia team come into the picture before us. And they take the patient wheel to either to the what you call the stroke team. If it is not intervention, then goes to the stroke unit. But if it is a stroke, interventional stroke, then the anesthesia team take over the patient and brings to the cath lab. And our team, along with the anesthesia team, they prepare the case at the cath lab. So this is a best protocol that we have actually culminated into to overlap the time of use of different teams and minimize the time for the intervention. Now, there are two imaging methods that we follow in acute stroke management. One is the CT protocol and other is the MR protocol. In the CT protocol, we perform plain CT scan, CT perfusion study, and CT angiographic assessment. Now, each one gives you an information. The CT protocol is the most important because you have to rule out that there is no hemorrhage. If there is no hemorrhage, then it's a case for ischemic stroke. And then we look at the aspect score, like in this case on the left side, you do see some discrepancy between the what you call density. But what you see here is a dense MCA sign on the right side. And one can actually consider this case possibly for occlusion here. But if you look at carefully, the ischemic insult is appearing on the left side. So this could be a vessel, what you call calcification because of the intracranial atherosclerotic disease, for example. So the stroke is on the left side. And the moment you do the CT perfusion study, what you look at, there is a penumbra over here, but there is a cerebral blood volume is also lost and the flow is also minimized over here. So there is already a core there, but there is some degree of penumbra also existing over there. And what you see here is that there is no M1 occlusion, but there is a very severe stenosis at the carotid bifurcation over here. On the contrary, we have MR protocol. MR protocol is more time consuming because to initiate the MR team itself, it takes time, and the MR study itself takes more time to perform. So largely we recommend in India, and I propagate that we should follow the CT protocol. There are exceptional indications. I will talk about, let's say, unknown time window when there is a, let's say, wake up stroke. For example, patient wakes up in the morning. We do not know when the onset was. I think directly we should do the MR protocol in those cases. So I will just, I was given understanding there are a lot of residents of internal medicine. So we do take into account the aspect score. The aspect score is that how much area of the brain has obliteration of the gray white matter or hypodensity appearing on the plain CT scan. And that we classify them into aspect score. And in the CT perfusion, this is the cerebral blood the cerebral blood flow. This is cerebral blood volume, which shows a small core, and this is the time to peak, which shows a large area of tissue at what you call risk, which is called a penumbra. All that you see on red is a penumbra zone and area of oligemia, which is a threat for core enlargement. So if you do not intervene in time and recanalize this artery, all that red is seen will become a black area or the dark brown area on cerebral blood volume study. That means there is no supply over there. So in this case, there are two possibilities. There is a large vessel occlusion with a good collateral, or there is distal embolism with restricted lesion. So this is what the one would like to look at. And here we can understand that there is no distal embolism, but there is a severe, what you call stenosis, ulcerated plaque over here. And maybe this patient had a small clot going into the peripheral artery, but there is a huge penumbra because of the severe hemodynamic perfusion deficit from the critical stenosis. I'll pass on to this because of the more time that we have. So on the CT versus MR protocol, the MR protocol is very useful in the patient where you are suspecting a brainstem stroke, because CT will not reveal any ischemia because of its what you call a small volume of the tissue and what you call the bony artifacts that you see around it because the Petrus bone and all. MR is a better thing to visualize that on the diffusion weighted image and on the flare, we can see these lesions very efficiently. Here is an example of a 70-year-old male with a wake-up stroke. NIH was just 4. And what you see on here is that there is a small, what you call basal ganglionic perfusion deficit, the TWI deficit over here, which is also, which is also seen in the form of ADC loss here. So that's definitely ischemia here. And on MR perfusion, you see this red is a large area of perfusion deficit. And on MR angiogram, you see there is a complete cutoff of the M1 over here. On the right side, you see MCA, but on the left side, you don't see MCA at all. So this is a case, ideal case for IV thrombolysis. We did an IV thrombolysis in this case. In 20 minutes, patient had a complete recovery. And in this, when the patient has a complete recovery, no need for thrombectomy. And this is the next morning. As a protocol, we do a complete MR repeat and MR angiogram. You see that a flare did not show any what you call abnormality, flare restriction over here because we did a reperfusion of this whole tissue. And on an angiogram, you see the recanalized M1 after the thrombolysis. So the moment you receive a recanalization, it is a equivalence, a high equivalence rate that it essentially gives rise to a clinical recovery, subject to the point that you act within the penumbra time when there is no core established. In that period of time, if you act, sometimes it is just 30 minutes time window. Sometimes you have a 12 hours also if it is a good collateral circulation. But in general, IV thrombolysis, we consider 4 to 6 hours maximum the time of window where the IV recanalization is effective. Does all the stroke revascularization need the same technique of if we consider the mechanical thrombectomy? I would say no. Again, as I said in the beginning slide, that it depends on etiology, nature of clot burden, technical challenges, and economic aspects, which I said in the beginning, again, just to say that. This is a patient, 69 years, male, right hemiparesis, aphasia, NIH of 10, window period 4 hours, aspect score 10. Here, aspect is 10 because if you see in these images, you don't see left and right any difference in the gray zone of gray area of the appearance of the deep nuclei and the cortical area. So there is no early changes of ischemia. That's why aspect is 10. So in this case, what you see on the angiogram is that there is a M1 occlusion, a tiny occlusion here. And on the angiogram that you perform on the DSA, you see clearly that there is a short area of contrast loss. There is a clot here, but there is some flow still into the MCA, but there is a penumbra. So what do you do in this situation is that you take your device. This is what we call the stent retriever here. And this is a suction thrombectomy catheter right at the point here. you retrieve the clot and do suction thrombectomy together. And you have in 5 minutes, within 5 minutes, you do a complete recanalization of this artery in single pass. It's a simple procedure, fast procedure. If it's to be done by learned person with the safety parameters and the technical aspect of this thing learned, and more importantly, the knowledge base to perform it, more than the technique, the knowledge base to when to intervene and how to intervene. On the lateral angiogram, you see that the complete corticogram is there. So you don't create any secondary stroke also in these cases. We learned that sometimes the result you can create in first pass itself, what we call the first pass. Sometimes you do a first pass, it doesn't open. You do again second attempt, it doesn't open. You do third attempt, it doesn't open. Now question arises that until how long we should continue to doing the passes. I, as a arbitrarily in my own understanding and my own mental calculation, I always define a strategy that I will do maybe 3 passes. If 3 passes consecutively are not bringing any reward to me in recanalization, I will give up. I will surrender to nature that, okay, I will not be probably able to recanalize this artery so that I do not harm this situation. By which, because each mechanical retriever that you perform is a trauma that you give to the endothelium and to the wall of the artery. And you are working in a shadow of the contrast on angiogram. So you should not see that only shadow. You should feel the tissue on the procedure. And now the results are published in some of the trials that are collectively like a multi-center registry of the cases. They found that a primary outcome would vary if you have a first pass versus multiple passes. And in this comparison, they found that TK3, and TK3 is a norm when you have a complete recanalization, TK2B or TK2C are the most effective recanalization in spite of there is no complete recanalization. Shows a better efficacy and safety of the procedure within less than 4 passes that you have performed. I would like to show you another case here. A gentleman of 60-year-old male, pronounced right sensory hemiplegia syndrome with a motor aphasia. NIH score at entry in the hospital was 7/42. This is also important that the entry point or sometimes the referring point, the NIH score is different. Sometimes referral center has a 7, for example. By the time patient comes to my center, the NIH score changes to maybe 9 or 10. And by the time I take the patient on the table, NIH sometimes changes to 12, for example. So it's that NIH score is also a dynamic process in our the management of these cases. IV thrombolysis was performed in this particular case immediately. They gave 7 milligram bolus and 56 milligram as a perfusion. Onset to needle time was 130 minutes. So it was a good time window. On CT angiogram, what you see is that there is a cutoff in the M1 segment on the left side. On perfusion study, you see a very small core or no core here, but large penumbra. So that means this patient has a very good situation to benefit because there is 0 core or very small core. And when you do angiogram, that you find that there is a M1 occlusion. So question arises that in spite of M1 occlusion, why there is a good what you call no core or small core. It all depends on the collateral circulation. What you see on collateral circulation, which is leptomeningeal here, almost to the tune of the M1 segment here, you have a complete filling of the retrograde filling in the capillary phase of this tissue. And you also have a collateral from the posterior cerebral artery here. So we go in with the solitaire and we open up this artery, and you in one pass, after the first pass, you get a very good result. And this is what you see, but as you go further, there is a reocclusion of this artery. It starts reoccluding here. It was much better before, right? And in 5 minutes or 3 minutes, it again starts reoccluding. So you have to go back again and you do a second pass, you open up the artery, but it is not very effective. And suddenly you realize that what is happening here is there is a severe stenosis or severe narrowing of the vessel at this point here. So here the mechanism is not that the clot coming from the cardiac source or from the large artery or the aortic arch into a normal middle cerebral artery, but here the middle cerebral artery is atherosclerosed. When the middle cerebral artery is atherosclerosed, it's going to have a reocclusion again and again because this is a ruptured plaque over here. So what we'll do as a strategy in this case is that we'll go up and we will do, we did until the fourth pass here. Either we do the stent placement or we just stop the procedure. So after the fourth pass, there was partial recanalization, M1 achieved. We always keep, as I was telling you, primum non nocere, because all these devices that we are holding are the dangerous devices, like a sharp razor knife kind of devices. So one should not use them again and again if they are not effective for 4 times or multiple times. So we stopped this procedure and we eventually expected this situation. I again come to this study that shows confirmation of the fact that if you stop, one should stop recanalization at least at the 4 passes. And if you go multiple attempts, it doesn't make any positive result, but it actually goes into a detrimental effect of the multiple passes. Now, as a matter of fact, we have to constantly think about what are the reasons of the failure. You know, the recanalization, when there is a clot and where you have a right device, why they are not getting recanalized? The same technique, why it should not. So we have to think on it, and there are many heterogeneity of the structural thrombosis that we have. Hard platelet-rich clot versus soft clot from the stasis, like in the atrium, in a fibrillating atrium, you have a much softer clot as compared to the hard clot that you see in a paraneoplastic state. Long length of clot versus short length of clot completely behave in a different way. Large artery atherosclerotic clot behave in a different way. Intracranial dissection, if it is a possible, is a disease or etiology. No matter what you do, it's a dissected artery already. It will not come out because it's a dissection. So you have to repair the artery with the stents or remodel the artery. Intracranial atherosclerotic disease, which is more common in the Asian population than the Caucasians, again has a different, the implications. So all these are the literature which are building up, and ICAD, which is a very important disease, and this is our study which we did in 2007, angiography based. ICAD, when we studied the pattern of the vessel involvement in a acute stroke patient or a stroke patient who were coming to us for secondary stroke prevention, we found that intracranial atherosclerotic disease was seen in about 27% of cases in isolated cases. But they were also associated with extracranial atherosclerotic disease, along with like a carotid bifurcation disease, but also with intracranial atherosclerotic disease, another 13% of the cases. So together, if you see, around 40% of the cases, we have intracranial atherosclerotic disease. And same is the what you call prevalence of the disease in other Asian population, especially the Korea, China. China has about 50% incidence of the disease. Japan, almost 39-40% of the disease. So we have an intracranial atherosclerotic disease. You have a multiple mechanism of the stroke. Stroke is not only because of thromboembolic phenomena are happening through the clot embolization. You may have a in situ occlusion of the plaque. So that means the plaque occlusion at the site of the thrombosis where the plaque is. Or you may have a distal embolism from artery, a small artery, to more distal embolism. Or you may have a perfusion failure because of the critical stenosis of the M1 segment, for example. So here is a case example. I just want to show you this disparity of the etiology, that this middle-aged person, relatively considered young this is the example from Zurich. So we consider 59 as a young patient there, but in our population, we consider middle-aged patient. So what you see here is that this patient has a good CT, no infarct on the CT, acute aphasia and right upper limb weakness, NIH of 2, we gave IVTPA, patient improved. That means lysis worked and absolutely fine. This was a what you call perfusion study at the time of the first time when the patient came to us. So when the patient improved, there was some stenosis in the M1 segment here. There was some perfusion failure. But when the patient improves, you do not take this patient for angiographic assessment and mechanical thrombectomy. Patient was kept in the stroke ICU, but the next morning, patient worsened again. He developed right hemiparesis and aphasia, but this time NIH was 8. We did again quickly the perfusion study. What do you see on CT angiogram? The M1, which was narrow, now got occluded. Now we clearly know that this patient has an intracranial atherosclerotic disease, which at the site of plaque rupture, the minute tiny clot which was there, it improved with the lysis and patient become fine. But it is ruptured plaque, so it again thrombose this point and complete this time. So M1 occlusion. So in this case, we will go immediately to the intracranial intervention. Here we can see there is a marking already. That other side also shows some degree of stenosis on the M1 segment. So this is the situation. We are dealing not with the M1 occlusion like a thrombus, but we are occlusion by the plaque over here. So the strategy of management will be different. Here, we pass the wire, we recanalize with the first suction thrombectomy, but we see reocclusion of the artery. We suspected that. And what we do see on here, carefully on this white image on the right side, that there is a ruptured plaque, very nicely visible here. It's a ruptured plaque. So when you have a ruptured plaque, we went with the balloon and we deployed the stent over here, and you see a completely normal circulation here with the peripheral normal flow without any distal embolism. So here the strategy, I will not go to the second pass, third pass, fourth pass, and innumerable passes, which are all going to be futile in this case. And we'll change the strategy to a primary stenting in this case. Again, these are not the standard procedure which are into the guideline at the moment or in the standard operating practices, but these are evolving knowledges that we have. And we are going to contribute more into the global literature because we have more incidence of these diseases as compared to the Western world. So the pattern of knowledge or pattern of disease and its evolution in the Caucasian, in the Western world will be entirely different than in the Asian population. So stroke is a disease where we will have a complete dichotomy of the knowledge and strategy of management in the East and West. I quickly go to another quick example, 83-year-old gentleman. We call them young patient because they come completely independent, and in the Western population, the Swiss population is quite independent. So they are all living their quality life independently at 86, 88, even at 90 years of age. Maybe they are climbing the mountain, going for hiking and everything all independently. So we want to give them a good quality of life. Now here I want to mention the point that the same patient which comes to parental Manna, for example, I would discuss in a different way with the family at 83 years of age, what they are expecting, the life and the support system and everything that they have with this patient as compared to what I would discuss with the family or with the referring physician over there in Zurich, for example. So this patient had a 1 NIH score, very minimal deficit, and MRS of 2. So he was dependent. He was not fully independent. Now here we wanted to give a good quality of life to this gentleman. So the CT was not showing any infarct and very minimalistic, what you call deficit. So we did an MR. What you see is a center, what you call central. So the white matter is small diffusion impairment over here. And corresponding on the perfusion study, what you see is in the same, this is called MCA-PCA watershed area, showing a perfusion deficit. So it is not a embolic stroke, it is a hemodynamic stroke, classical hemodynamic stroke. And this is because of the fact that this trunk of the MCA has a very severe stenosis of 90%, right? And this patient is now, if the blood pressure goes down, the watershed area will suffer the ischemia more, and patient will have an increase in the deficit and might go into an irreversible stroke in that area of watershed infarct. So this stroke will be treated by acute stenting. Here we call it as a mechanism. A stroke is a perfusion failure, right? hypoperfusion. So we just go and do a stenting in this case, nothing. So we did a earliest secondary prevention of a stroke in this case, not acute stroke treatment, but the earliest secondary prevention of a stroke. Kindly look into the time, and you can intervene and ask me to stop at any point of time. Is that fine?
Please go ahead, sir. No problem.
Okay, all right. Okay, all right. So we go to the next example. Again, the mechanisms are always different. 80-year-old gentleman, left hemiparesis, NIH of 6, aspect of 9. Window period 3 hours. Very good. That means good for IV decanalization as well as for intra-mechanical thrombectomy if required. So this patient undergoes the procedure, and what we see is that there is a complete occlusion of the left-sided, the right-sided internal carotid artery over here, the bifurcation. But he has a good circle of Willis, collateral circulation is nice, so he's surviving. And now we can correlate with the perfusion study. There is no what you call very minimalistic, I would say, cerebral perfusion, cerebral blood flow and cerebral volume loss, but there is a large area of penumbra. This yellow and green, yellow and red thing on that TPP, or the time to perfusion, time to peak perfusion, is what you call is a perfusion deficit. So in this case, the procedure would be we just do a recanalization, acute carotid stenting. This is an occluded artery, but we know that this is an acute occlusion. This patient has a severe stenosis. On the top of that, he had a acute rupture of the plaque, and the thrombus caused the occlusion of the artery. So we do the angioplasty here and deployment of the stent, and you have a remodeled artery and a completely normal circulation in this case, and without changing the the parameters on the diffusion pre and post. You have a complete recanalization of this actually. So the recanalization strategy, always I would say that in medical management, whether we do a chemical management, or I would call it a pharmacological management, or a conservative management, also an important step of management, or interventional management that we perform, has to be based on a constant evaluation of risk benefit, what you call equilibrium that we have. And in the stroke, this is a dynamic phenomena. Again, as I said, it constantly keeps changing. So one has to keep changing the decision also about any intervention that you perform. So on one side, you have on the risk benefit analysis, you have a revascularization strategy, technique of mechanical thrombectomy, success versus risk, type of occlusion, collateral circulation. And on the other side, your predictability or possibility of recanalization of that artery, risk of the procedure, and another most important thing, risk of the reperfusion injury. Because sometimes if you are delayed in your reperfusion of the infarct, if you have already achieved the infarct, and after, let's say, 8 hours, you recanalize the artery after 4 hours spending into the procedure, and you say, I did it and a beautiful result angiographically. But you go into the stroke unit and patient deteriorated, you do a CT scan, there is a massive reperfusion injury. That means hemorrhage in a red infarct, white infarct converts into the red infarct. So reperfusion, these are all dynamic processes. They all has to be constantly evaluated for decision making, which is in the middle. Here comes again, I want to emphasize as a learning point, teaching point, I always emphasize, primum non nocere should prevail constantly into our mind, which is Hippocrates decided in 460 BC, actually, which remains, I think, valid and true and perfect even today. So in the last few slides, I would like to discuss the global burden, epidemiological aspects of a stroke. It's a huge burden globally. It's the second leading cause of death. 5 million deaths each year we have from the stroke. More importantly, it causes permanent disability, and the first major cause of permanent disability, which is almost to the tune of another 5 million per year. And this is of great significance, especially to us. in the developing countries and underdeveloped countries, because stroke is implicating now to the more younger population. And younger population means when they develop stroke, they may not die, but they become disabled vocationally. And many times the whole family survives on that single person. So if you lose that bread earner with a disability, for example, then you lose whole family into a devastation. So the implications are many, many fold more in our environment as compared to the Western environment, where they have a very good foolproof support system, even to the rehabilitation care to a disabled person and the elderly population. Very beautiful one. Like in Zurich, in Switzerland, I learned that they have such a beautifully carved, foolproof system, which is a dream for us. I think for the next 500 years, I don't think, even if we work passionately with all our resources and all our abilities, all our commitment, it will take 300 or 400 or 500 years to achieve the target, like Switzerland. But I think we can make a difference, even if we raise 1% significance, because 1% of the 5 million or 1 million of disability in India would be a large number of patients we will be helping out to. I am not trying to say that it is the sorry, I lost my track. It is the intervention which will bring the difference. Not doing intervention by better understanding of that stroke will also give a good outcome to the patient. So important thing is that today the neurology has expanded into multiple areas of specialties, and neurology is no more a specialty subject. It's a subspecialty involved into each verticals. Like movement disorder is a vertical in itself, is a huge implication. Epileptology is a huge implication. Similarly, vascular neurology, stroke is a big pyramid or big, the kind of subspecialty. So in terms of our resource development, especially the human resource development, we have to take an approach which is more specific for the qualitative development of the manpower. That's a need of the hour that we have. Doesn't matter that we have in large masses, but we have significant number of people with a high quality performance, so that they develop more and more quality people around them. That is the need of the hour, I personally feel, and that we are trying to achieve through our foundation by expanding the education and training to the young breed of neurologists who are getting committed to learning this subject and practicing this subject. Now, the total cases in 2019, this is a WHO, what you call the global data that I have picked up, is 12.2 million total stroke cases. The incidence of ischemic stroke is almost 8 million, and another 4 million is a hemorrhagic stroke. The incidence of subarachnoid hemorrhage is almost 3.5 million. This is another area which we are targeting to the interventional treatment, because endovascular treatment of aneurysm is far more superior and far more rewarding and quicker than the surgical in general. I'm talking about. I'm not talking about the individual institutional practices, because what we limit is today is the availability of the procedure or availability of the technical expertise, not the procedure. Many places the procedures are available, but they are futile in my view, because they are not technically sound. They are abortive attempts by the poorly trained people or unqualified people performing these procedures, because there is a high demand for the procedure and there is no supply of the qualified people or technically developed people. So the gap has to be seriously thought about by the medical community, especially those who are involved in the strategic planning and development of whole, the future of these things in next 5 decades or next 10 decades that we have ahead. So by showing you these high number of these data, I would say that we have a very high, the burden of the disease. This is an important slide which I have is given to me by one of my fellow colleagues, Professor Shitesh from NIMHANS. He has built this study where we are comparing that this is a stroke knowledge network from the Netherlands database, that how the awareness changed the outcome of the disease or a reachability of IV thrombolysis. When they started in 2005, the reachability of the IV thrombolysis was to the tune of 6% of the stroke patients, which over 2012 reached almost to the tune of 14%. This was, and this was a very orchestrated, aggressive campaign that the Western world, they did, especially the North and the Central European countries. And corresponding to that, he has put up this nice data, the NIMHANS study in 2017. And the most of the government hospitals in that region of Bengaluru, major semi or quasi-private hospital even, the reachability was 0.5% in 2017. So vis-a-vis what the rest of the world was 6%, in 2005, we were 0.5% in 2017 to IV thrombolysis, reachability. And today, this is the Berlin Tyrol study has almost to the reachability to 80%, what you call needle to, what you call this time, which is reaching to almost 16% of the stroke patients. What we have reached in 2019 in NIMHANS, they found in their data that they reached to almost about 4%, but they did a lot of effort in educating internally the people at the emergency triaging and deputing the acute stroke neurologist residents over there in the triage, neurologic triage actually, and they obtained almost a 4 to 5%. And in 2019, they achieved almost close to 9% of the reachability. And more or less, the Sri Chitra Institute also did achieve the same parameter actually. By this time, sorry, I'm repeating this again. So this almost similar 9%, the Sri Chitra also published in 2019, their study of internal institutional reachability to the IV thrombolysis. Now, there are several reasons, and we can discuss, this could be itself a longer discussion of maybe a couple of hours, that what are the reasons for, the poor reachability of these in our environment, which are completely different factors, right? Socioeconomic status to our transport situation, to our unawareness and the practice patterns and inertia at several level, and non-availability of infrastructure and so on and so forth. There are multiple parameters which we can discuss upon. So stroke neurological emergency, rather first time truly a neurological emergency is being apprehended or approached as a true emergency situation. Because in the past, we never approached stroke as an emergency. We approached with a nihilistic attitude, with a tablet of aspirin in our hand and a consolation to the patient that, yeah, maybe you have to go for a aggressive physiotherapy program, and that's the only way. The time will probably give a recovery. Time even today gives a recovery. Time is the most potential and most powerful dimension in the management of the stroke. But we have to chase that time with our intelligent intervention and or intelligent withholding of intervention in these cases. So interventional treatment specifically has applied more and more to the cases now. It has also given us a better understanding to the whole pathophysiology and evolution of the stroke treatment in this regard. So we have moved from time is brain, which used to call to brain is time. I call it today we have gone to better understanding to what we call the understanding is a brain. So if we understand the whole mechanism, which includes time as well as the collateral or tissue tolerance mechanism in a given situation, which depends largely on the collateral circulation and the penumbra effect. If you understand the whole concept, then I think we understand the brain and we bring the brain back. Sometimes even the window period could be as long as 18 hours, and we can reverse the stroke. And on the contrary, there may be just a 30 minutes of the window period, but the perfusion study parameters are such that don't give IV thrombolysis even because it will cause deperfusion injury because there is already large cord set in 30 minutes. Though the window period is up to 3 hours for the IV use, but it's a futile exercise. So you have to make an intelligent exclusion of your own cases in spite of that fact that by standard paradigm of standard what you call IV lysis protocol, that case required to be given IV thrombolysis. That becomes a mechanistic approach. So in the end, I would say doing something is not always better than doing nothing, nor it is appropriate to start doing these procedures because of the fear that somebody else will perform. What I do hope that the neurologist known for their scientific approach and critical analysis of data can guide the development of these procedures in a more scientific path than they are heading now and so-called mechanistic or autistic way. This is the slide actually I have picked up from my early presentation I used to make more than 2 decades ago. And I was aggressively presenting in my neurological community to stimulate interest of neurologists into this sphere. At that time, we were far away from acute stroke, possibly going to be as an interventional management. But as a young student of neuroscience and vascular neurology specifically, I was foreseeing this opportunity actually. So I was trying to stimulate this thought, this slide even becomes appropriate today because in 20 years, I don't think we significantly changed our mind in terms of how to stimulate training programs, even in the larger institutions of our country, unfortunately. By acquiring a skill only is not sufficient. The important thing is the knowledge. The neurologist and the neurosurgeon would not only have the satisfaction of helping their patients by weeding out the procedure which are potentially harmful to them actually, by withholding the procedure, as I was saying, primum non nocere, but also will position themselves as a natural choice for these procedures. Recent development in the stroke treatment suggests that neurologists should expand into new areas of care. It is a mistake in my judgment if we avoid aggressive pursuit in training neurologists, especially in interventional techniques, because we need large number, something about 3,500 neurologists or neurointervention. Doesn't matter where they come from. They may come from neurosurgery. They may come from our neuroradiology, especially who are DM neuroradiology. We acknowledge them because they understand, they go through the vigor of training of neuroimaging and neuroradiological understanding of the whole phenomena of vascular imaging and tissue at risk and tissue survival and tissue at threat, everything, which is important. So in conclusion, I would say that acute stroke idiopathogenesis is diverse. Mechanical thrombectomy is not the answer to all acute revascularization. Understanding the etiology and the mechanism of the stroke is important to make revascularization a successful strategy. In conclusion, again, I will say IV thrombolysis remains the front line. It's all in organizing the stroke. Why I call it the vascular neurology group to be organized, which remains totally committed 24/7. Because majority of the stroke, by the way, come in the odd hours of the day and night. You're ready to go for a party and you get a call. You have to cancel your party and go to the lab. Or you are after a late night movie, you are just going to the sleep and you get a call at 2 o'clock that you have a stroke. So you have to rub your eyes and go into the cath lab. So it requires an immense dedication 24/7, not for few days, not for few weeks, not for few months, actually for your long practice that you have, maybe 30, 40 years ahead. So that level of commitment, if you have, then only you can transform into a committed person. Otherwise, it becomes an abortive attempt. You otherwise give up at a point of time that I have done enough now, or I'm in a deep sleep, or I'm in my personal appointment. Let me make an indication is a borderline. Let me cancel this indication. So these are the common things that we rationalize in our favor. And intelligent thing is that there is a large gray area in medicine. And we are very sharp, intelligent people as a physician. If you want to make it positive, we convince the patient that it is important for you. If you do not want to do it, we convince them it is not good for you. So we defined a border gray in the middle of the area gray zone for our rationale, where we include our biases of our doing. So we also use a term called in medicine, we use a terminology called intention to treat, right? It's a research protocol. In the research studies, we say, we did this procedure with the intention to treat the patient. That means every time your bias was to do the procedure. Very clear. So you display your bias about it. So we are aware when you did the scientific study, there is a complete bias involved for doing the procedure. So we have to analyze the result and outcome accordingly in that statistical sense. And that is very important in my personal view, that how we create a committed program in this regard. So as a matter of fact, I'm happy to be delivering this talk to this organization, which so far I've heard about it. In fact, one of my chief nurse comes from the same region, and she always used to invite me to that area, to her home, and attraction she used to give is that there is a huge big hospital, you will like it, it is beautifully created. So I'm very happy that there are beautiful centers I'm seeing across in Kerala, and I'm investing a significant amount of my time in developing multiple centers in this region of India, where somehow Perintalmanna became a nodal point by de facto over last 18 years. And I would like to acknowledge the effort of Dr. Haq to bring me here in the very early time when it was in the Taluka hospital, a cooperative hospital with no facility. We have to fight at time with the cardiac cath lab, which we are still fighting with them. And these are challenges which are in our practical world. But still, I would say that without succumbing to those challenges, because it was easy for him to say, yeah, because we don't have time to access to the cath lab, rest of the world is also not doing it, I will also not do it. But he was just pulling me here and organizing workshops like every month and every second month, a workshop here collecting 10, 15 cases. And it became a nodal point for large number of actually the practicing neurologists and interventionists in Kerala today. They all started coming to Perintalmanna to learn and get not only learn, but to get motivated also. So I'm happy to be with this association, and I thank you very much for your kind time and attention. So in the end, I would say, if you have any questions, I know that there would be many questions. If you do not have a time limit, I would be ready to answer any question that you have.
Anil sir, Jobin sir, please, you can take over, sir. Any questions?
So I have a small question. Do you regularly do CT perfusion before mechanical thrombectomy?
Absolutely, absolutely. This is the protocol that I have been proposing to Indian professionals at every forum that I was invited to over last 10 years. Even before we started these, we were doing a experimental way, some mechanical thrombectomy, because we have been doing mechanical thrombectomy even before MR Clean published. So CT perfusion is a very important tool to give you lots of information, let's say a confident inclusion of the patient and confident exclusion of the patient from the protocol of doing a procedure actually. So CT perfusion is an important parameter. And I would like to tell you that at Perintalmanna, at this centers, since we started our dedicated, what we call our mission of SNF Center of Excellence over last 2.5 to 3 years, that whole project we have taken SNF Center of Excellence, we have essentially developed all cases with the CT perfusion and CT angiography protocol. Not only that, if the patient is undergoing MR protocol, We are doing MR perfusion study also in this Taluka hospital. I'm very proud to say this because in my hospital in Max in Delhi, we were not performing MR perfusion. Nobody will do it even today. You know that MR is so busy everywhere. No, I'm sure there are many radiologists and neuroradiologists, and they would agree with me. They are so overburdened with the machine because the hospital doesn't provide them the second machine or dedicated stroke machine. Unless you have a dedicated machine, you cannot perform the quality investigation because these are time-consuming procedures. And you cannot develop a dedicated knowledge base, whether neuroradiology or the neurointervention people behind them. You have to have a dedicated machines. You can't say, okay, I buy one Boeing and you take it for fighting fighter jet also and fly when you are not using for, because there's hardly a war. You fly it for, the public transport. You can't do that. That's what the whole country is doing at the moment there. But now today it is in a standard operating practice. These are standard, the demand, the procedure the patient requires from the hospitals. If it's a tertiary care hospital, if they are serving as a stroke centers, they are demanding, are you doing this mechanical thrombectomy? If you're not doing, then you must display ideally in a legal manner that we are not what you call empty, prepared centers, so that the patient has a informed consent to enter the hospital. But I know it's a too idealistic and too far to expect our environment.
Thank you, sir.
Yeah.
Thank you.
But CT protocol, I would say, can be easily developed. You just have to sit down with your neuroradiology people, and you just have to enforce and see that we do in all these cases. Initial few runs, your participation together would be very, very helpful to them also to understand the whole thing and to set up the protocol. If you run 10 procedures, I'm sure after that the technicians also become well versed and you can run it. It requires just 10 minutes. It's a 10 minutes, less than 10 minutes protocol, doing all three things together. So it's a pretty fast study. Yeah.
Thank you, sir.
Jovan sir, from your side. Yes, sir. Sir, is your this thing muted? Is your mic muted?
Hear me now?
Yeah.
Okay. So I hope there are no more questions. So we can conclude this session. I thank Dr. Zakir Hussain for a detailed talk. Just like stroke, the management of stroke is also very dynamic and it keeps changing. And I thank sir for throwing light into all the new concepts, just like the first pass concept, which is something new to me. So here, the neurology department under Dr. John K. Jones' leadership, we are trying to provide tertiary care for all stroke patients, and Dr. Anil is spearheading the intervention wing. So association with learned people like you will help us in serving the society better, and we look forward to communicating and associating with you in the future. I once again thank Dr. Zakir Hussain for sparing your valuable time with us. Thank you, sir.
Thank you.
Thanks.
Thank you. Well,